Hi, I am Vijay Jayaraman, a member of the Emergency General Surgery Committee of EAST. I'm here to discuss the Practice Management Guideline, Clostridium Difficile-associated disease, timing and type of surgical treatment. This was developed by Ferrata, Velopoulos et al. And published in Journal of Trauma in 2014 using GRADE methodology. There were two population intervention comparator and outcome questions defined for the study. PICO question 1. In adult patients with CDAD, does early surgery compared with late surgery, as defined by the need for vasopressors, decrease mortality rates? And PICO question 2. In adult patients with CDAD, does the use of total abdominal colectomy compared with other types of surgical interventions decrease mortality rates? For the literature search, mesh terms alone or in combination were used, including Clostridium difficile, colitis, colectomy, surgery, and mortality. The related articles function was used to broaden search and scan for all citations. Randomized controlled trials, prospective observational or retrospective studies, and case-controlled studies were included. Total abdominal colectomy or subtotal colectomy were compared to exploration, ostomy, or segmental resection. Of 62 papers originally screened, 38 were eligible for full-text review, of which only 32 were suitable for the qualitative synthesis. For the meta-analysis, 8 papers were used for PICO question 1 and 17 papers for question 2. For PICO 1, overall mortality ranged from 19% to 80% across studies. In general, there was lower mortality if operation preceded shock or organ failure. There was some data to suggest that earlier operation in terms of days from diagnosis also had lower mortality. Progression to use of vasopressor was the most commonly used term, and so was used as a measure for early versus late in the 8 studies included in the meta-analysis. The forest plot shown on the slide shows that early surgery was associated with less mortality with a relative risk of 0.5. In adult patients with Clostridium difficile-associated disease, the authors strongly recommend that patients undergo surgery early, that is, before the development of shock or need for vasopressors. This recommendation is based on very low quality of evidence, but takes into account a high treatment effect of over 50% mortality reduction. For PICO 2, there were studies that showed worse outcomes for total colectomy without statistical significance and did not specify if lesser procedure was performed first with subsequent colectomy. One study showed 100% mortality for segmental compared to 14% mortality for total abdominal colectomy, with presence of peritonitis suggesting worse outcome. 17 studies had enough data to perform meta-analysis between outcomes of total abdominal colectomy and segmental or no resection or ostomy. When looking at the primary surgery, relative risk was worse, 1.11 for total abdominal colectomy, but this changes to favoring total abdominal colectomy, 0.86, when considering the final procedure performed, and that is why there are two forest plots that you see on the slide. In adult patients with Clostridium difficile-associated disease undergoing surgery, the authors conditionally recommend total or subtotal colectomy versus partial colectomy or other surgery. This recommendation comes from very low quality of evidence.